Thank you for joining us today for this month's Road to Interoperability Forum. We will get started shortly as people start to sign in, so thank you for joining us. Welcome, everyone. My name is Denny Brennan, and I'm the Executive Director of the Massachusetts Health Data Consortium, and I want to welcome you to this month's Executive Forum on Interoperability, or what we entitle, What is Interoperability? We've been having these discussions each month since the beginning of the year, and we're starting to drill into more specific aspects of what interoperability entails. And today we're going to be talking a bit with some industry experts about a critical aspect of interoperability, which is the dual components of identity and authentication. We live in a world where who we are is difficult to set certain in a digital context, both for ourselves, knowing that passwords and usernames are increasingly less useful in determining or defining that we are who we say we are. And we also live in a digital world where people need to know when they do business with us or on our behalf, either through taking care of us as patients or managing the delivery of other healthcare services or financing those healthcare services, they need to know who we are. And that's become increasingly important in healthcare. And I'm very excited to welcome three industry experts today to join us and discuss this very important element, this very important aspect of interoperability. Before we get into this webinar, I want to go over a couple of housekeeping items with you. Today's session will be an hour, but we will stay around, that is we being the MHDC team, for 5 to 30 minutes after this discussion, from 10 to 10:30, to answer any questions or continue conversations that folks in the audience would like to share with us. We welcome our guest experts to join us for that, but they're not expected to be there if they can't make the time. So we'll be able to continue for an extra half hour, and we encourage you, if you have questions, to stay for that time. This is called a forum for a reason, and the reason we call it a forum is we used to do this in person. I mean, it's a long time ago. It's fading in our memories of our meeting in person and having roundtable meetings. But the idea of a forum is that there is a back and forth between presenters and the audience. We're all sitting at the same virtual table. So we really encourage, welcome, that you respond verbally, you raise your hand, you put your questions in the chat or the Q&A, and we will, by whatever means possible, follow up with your questions or hear them from you directly and do our best to answer them. As you know, this meeting is being recorded, and we will have it available on our website within 24 hours. Following the session today, a Zoom survey will appear as you exit the meeting. We appreciate your taking the time, all of 30 seconds, to complete that survey and share your feedback with us afterwards. Our co-chairs today are David Carusio, the Chief Technology Officer at Point 32 Health and the Chairman of our Board of Directors, and Bill Young, the Chief Information Officer at Berkshire Health Systems, who is also a member of our Board of Directors. David will be joining us shortly, probably around the half-hour point in today's discussion. Bill, like many who are not on today's forum, is on vacation, so we wish him a good time, and he'll be sorry, and he's expressed his disappointment at not being able to join us today. But we are a consortium, so our board members represent the health data community in Massachusetts And we are a non-industry, we're not an association that supports one segment of the industry as opposed to a consortium that brings all the segments, all the members of the health data community together. So we're delighted to have in our co-chairs two individuals who represent both the health plan side and the healthcare provider side. So moving on, MHDC's Executive Forum offers a high-level view of interoperability from its regulatory, technical, and industry roots to its essential components and features, and to the programs and projects it enables, with a focus this year on health equity and patient experience. Our monthly forum sessions feature government, industry, and MHDC membership experts who help facilitate conversation, help stimulate the dialogue, and participate in an active discussion that enables us to get more knowledgeable as a community on what is this thing we call interoperability. As you can see, I'm thrilled to welcome three guest experts to share with us their insights into this essential but complex notion of identity and authentication. And we couldn't ask for three better spokespersons to share with us their insights. Joining us today is Julie Moss. Julie is founder and CEO of EMR Direct, and Julie has a product management background in enterprise and consumer settings. Julie's previous roles include managing various stages of software development at MicroStrategy, NBC Internet, and Yahoo. Julie holds a bachelor's and master's of engineering degrees in electrical engineering and computer science from MIT, and an MBA from the University of California, Berkeley. Julie is a DirectTrust board of directors. You'll be hearing a bit about DirectTrust as we talk, and co-chairs the FHIR at Scale Taskforce, or FAST, identity team. Also joining us today is Kyle Neuman. Kyle is a visionary cryptography engineering leader and the director of the Trust Framework Development at DirectTrust. As a subject matter expert in bridging the gap between business needs and applied cryptography, Kyle developed strategy, policy, and architectures for DirectTrust, which is the acquiring entity of SAFE's identity assets, in alignment with the greater DirectTrust mission to instill trust in identity and information exchange across the healthcare sector. Trust is a key word, and we'll be hearing it and discussing it today. Previously, Kyle served as managing director of Safe Identity, where he was responsible for rebuilding operations, developing its associated services, and leading the industry consortia to fulfill its renewed mission. Third, but by no means least, is our friend and colleague Ryan Howells, who is a principal at Levitt Partners, based out of Washington, D.C. Ryan works with the White House, Congress, Health and Human Services, and the VHA on healthcare policy and interoperability issues. Ryan currently leads the CARIN Alliance, a multi-sector public-private alliance focused on giving consumers greater control to and digital access to their health information. Ryan is a board member for multiple healthcare companies. He also is on the CMS MITA Governance Board, Care Quality Steering Committee, ONC's Fast Identity Tiger Team, and the VCI.org Smart Health Card Steering Committee. Ryan has an MHA from the University of Southern California and a Bachelor of Arts from Brigham Young University. Julie, Kyle, Ryan, thank you for letting me introduce you as having such illustrious panelists. It does take a little bit of time to do an introduction, and I appreciate your sharing your patience and my welcoming you to our forum. So let's talk a little bit about this notion of identity and authentication. Ryan, why don't I start with you? Can you explain how identity, authentication, and authorization are different, and the role that each plays in a system, in a modern health data system, or as we would describe a system that uses APIs for data exchange?
Sure, Denny, and thanks for having us today. We really appreciate it. And I'm going to give kind of more of the layman's answer, and then Julie and Kyle are going to give more of the technical answer in terms of being more accurate on this topic. Identity is simple. Are you who you say you are across different systems? Authentication is, can I securely be able to access data within an individual system? And then authorization is, do I have permission to access that data? Do I have the authorization to access that data? Each one of those are important, and each one of those play a role. But we need to start to think about that differently in a world that likely will be governed by TEFCA in the future. We have thought about that inside of our firewalls as it relates to how that actually operates, but it hasn't been as significant of a deal because we would get a vendor and allow folks to be able to authenticate themselves into that environment and be able to gain access to the data. Pretty straightforward. There has been some issues with the proliferation, obviously, of different applications that are out there and things. So there's pain in the sense that I've got to remember all these usernames and passwords, and why do I have to remember all of that stuff? But that pain is going to get even more acute and more complicated when we start to exchange data nationwide across multiple systems, multiple entities with multiple different permission systems. And so we've got to work out a way in which we can solve this for the whole country. These three kind of ideas. And I like the fact that you mentioned, Denny, at the beginning about trust. I've said many different times, the next decade is actually going to be determined by who do you trust, and how is that trust actually being shared across a network, and what does that look like? Trust is absolutely critical and essential to our ability to have nationwide data interoperability, and we have to trust someone or something. That's the only way that this is going to work, and whether we trust the private sector, the public sector, some combination of the above, which likely is going to be the case. We've got to figure out where that trust lies, and then how we can actually be able to share that trust across an ecosystem of data holders. But I'd love to hear from my panelists on hoping to correct me if I went astray there.
Julie, what are your thoughts?
Oh, I think, Ryan, that's all good. Obviously, we the three of us talk about this a lot together, and obviously Ryan's got a great handle on it. The other things I would emphasize is I really see, obviously, working on the identity team as I do, that identity is foundational to all of this. And today, everyone remembers that cartoon from a while back. No one knows you're a dog on the internet, right? We're kind of finally getting around to solving that problem. The cartoonist didn't mean, I don't think, to introduce the problem, but we find we're at a lot of conversations, and you all probably are too, where that's brought up, because we really don't, at scale, have mechanisms for understanding who someone is on the other side of an email, or especially we're concerned about it on the other side of a FHIR transaction, right? So for a long time, my organization participated in FHIR connect-a-thons. We went to test. Always there were open servers and test servers where authentication really didn't matter too much, not at all. You're required to test with systems that don't have any PHI in them. So we're always not really too bothered about sharing usernames and passwords on the Excel spreadsheets that list which servers you're going to test against. So we kind of saw this point in time arriving several years back, and took some time to really think about what would be an architecture that would really support what folks need to know to make those authentication and authorization decisions Ryan spoke about just now. And really, through years of fast collaboration, both on the identity team, on the security team, which is a whole different group of folks within FAST, and other aspects of FAST, there's a directory team, reference implementation builders, and a lot that goes into FAST. If you're not familiar with the entity of kind of an army of volunteers at this point, It's been very orchestrated what would go into preparing a confident FHIR transaction ecosystem. And identity is really at the core of that. It's a building block that for 5 years, the ONC FAST Tiger team has been thinking about and analyzing and having, a deep dive conversation for at least a whole meeting. Probably we had a couple of meetings just about biometrics, for example, and analyzing what biometrics might be suitable in a FHIR transaction to help build confidence, or what metadata over several meetings and really years of thinking is most informative to help match on a patient, and what level of identity verification is both equitable and scalable and could really get anyone in the nation identity verified and set up with a digital credential, but also strike the right balance of being sufficient to let a health system want to release data to someone who's been verified at that level of assurance and for whom the right demographics have been included in a match request. So I would emphasize identity, as something that's kind of an essential ingredient. Identity is then, as I alluded to, communicated in an authentication event. So when I go, it's called identity proofing for a reason. I am proving I am me. In the authentication event, either I'm using some strong assurance authenticators to reliably tell a health system I've signed in with this digital identity, or I'm repeating the identity verification process de novo if I've lost my credentials and need to recover them, or if we are creating credentials de novo where they don't exist, or where I have to bootstrap them at a third-party identity provider and share them with a service that I want to sign into. So that's kind of my lay of the land about where identity meets authentication. An important piece I would mention as well is that the Fast Identity Tiger team considers identity proofing to be really tightly coupled with patient matching in a way that over the years has made folks a little bit uncomfortable, because it's not supposed to be that way. It's, one is a separate thing from the other. But what we have done over the course of the last 5 years is to really distill down the aspects of identity verification that could be prerequisites to matching events. So our vision for better matching, better probabilistic matching that will occur for some time until digital identifiers proliferate, is that if we have a high assurance identity proofing event that precedes a match request for a patient, then the demographics that you put into a probabilistic match request are all going to be high assurance, consistent with a proofing event. The name is going to be spelled right. The address is going to be consistent with what USPS uses textually to describe that address. And all of those demographics are going to be consistent with an identity proofing event for a person. So when you go to submit those in a query to an information responder, you know that they will all correspond to some unique person in the real world. So we're stripping out a lot of the potential mismatches and patient safety concerns by really front loading identity verification into matching. And then in the Fast Identity IG, later we will impose some identity management requirements on responding organizations too, to make that matching even better. I didn't touch on authorization. I feel like I've spoken enough, and I'm gonna leave that to Kyle.
Well, Kyle, why don't you pick up from there and let's get your perspective on this and on authorization as well.
Sure, happy to. Thank you, Denny. And I agree with what both of the panelists have said on this topic so far. If you don't mind, I'd like to start first with a little bit more on authentication to give a little bit of a different perspective on sort of what its role is in these three contexts in identity. Somewhat of a controversial statement might be that authentication is optional. You don't actually have to have authentication, but boy, without it, life is really hard. So really, the purpose of authentication is to prove the same person that was identity proofed is returning to the service again. And usually it's done with some kind of a secret, what they call factors of authentication, something that you have, something you possess, maybe a phone, some kind of a hardware security token, something you are, like a biometric, or something you know, like a password. These are all secrets that you know, and ideally some kind of a server also knows, or can prove you have possession of. It isn't actually necessary to get access to a service, though. Another alternative, which is not desirable, is to go to the service and be identity proofed every single time you want access to data. That is another option. And in which case you wouldn't need authentication. So every time you wanted to get into your Gmail account, for example, let's say that it was required a high level of assurance to get access to that Gmail account, you would need to be identity proofed each and every time, presenting your driver's license, making sure you are who you say you are, a very time-consuming process and something that none of us want to do. This is why authentication exists. It is a much faster way to prove who you are in lieu of identity proofing, provided that that's happened at least once and they have bound these authenticators to your account. Now, as Ryan pointed out, authorization is fundamentally distinct from digital identity proofing and authentication, in the sense that no amount of identity proofing or authentication will prevent an authorization type of attack or breach of some sort. Authorization fundamentally is, as Ryan put it, do you have permission to access this information? So it doesn't matter how many times you prove your identity or how well you authenticate. If authorization controls are not put in place, then someone may get access to data that they're not supposed to. And this is a really hard problem to solve. It's, number one, difficult to distribute across the United States so that one person can state on their own to every health system, I want to share my data with this individual. Generally, right now, that occurs at each individual holder of data. They have to tell each holder of data who is allowed to get access to their data. And in general, that sort of is one of the biggest problems with, well, I won't say biggest, but boy, it's a tough one. And it also is the final step as well. You'll start with identity proofing. Who am I? You'll follow typically with authentication so you can quickly get access to that data. Once those two things are in place, then authorization is able to take place, but it only happens after the first two have occurred.
Thank you. Why don't we move to our next question? This has been a very helpful discussion. And again, I encourage folks in the audience to please ask questions, and feel free to, no question is a bad question. This is a very complicated area, and all of us are probably thinking, I have the dumbest question I could possibly think, and I don't know if I should ask it. And I can assure you that that is probably a very good question. So, and one that everybody in the room would gratefully nod and say thank you if someone would ask that question on their behalf. So feel free to be a bold pioneer when it comes to asking questions. Let's go to number two. How do reusable digital identity services work? Some of the things that we've been talking about involve a patient setting sort of the parameters. I am who I say I am. You have the means to know that I am who I say I am, and I authorize you to use my information or not for very, increasingly specific purposes. But a lot of this, of what we're talking about, is also business to business exchange, where, these credentials are embedded in transactions that the individual person might authorize to happen on their behalf without there necessarily being an active participant in this. How do these identity services, these reusable digital identity services work, and why are they an attractive choice? What are the reasons that someone might decide that they're not the right fit? And Kyle, I'll start with you on this. If you could give us a sense of this idea of reusable digital identity services, and the fact that this is not just person to business or consumer to business, but also embedded in business to business transactions.
Of course, yeah, it really is a great question, and this question kind of underpins the rationale of why a trust framework is necessary. Without a trust framework, you cannot really have a reusable identity. If somebody identity proofs somebody once and they want to use that somewhere else, well, that somewhere else will most likely have had to agree that that initial identity proofing event is good enough for them. And doing that over and over and over again across healthcare is just simply not scalable. So the ideal state of a reusable identity is one in which it scales automatically. And that is hard to do, not only technically, but there are other business reasons why it's challenging. Generally, it all relates to risk, whether it's legal risk or cybersecurity risk. Being able to just trust a digital identity that was created somewhere else takes some understanding. It takes a lot of knowledge and comprehension that you're not jumping into something that's untrustworthy. So that really is where a trust framework comes in. It sets ground rules for what every identity proofing event and authentication event needs to adhere to so that everybody can trust that everything is operating at the same level. So they can rely on these other credentials freely, because ideally they had a role in defining what those criteria are, what the requirements are, and they understand the risk in relying on these credentials, and they can mitigate those risks within their own organizations. Basically serves, as Julie put it, as a floor, basically, that everybody can understand. So generally speaking, there are many use cases for reusable identities. They are, however, at the moment, somewhat still of an ideal, but we are changing that. Actually, in fact, the three of us, Ryan and Julie and myself, are working to change that as be less of an ideal, more of a reality. But ultimately, the use is, a great example would be allowing a patient to get access to their health information across many different health systems. That is where reusable identity has tremendous value. It's not the only place, though. Virtually any business environment where more than one organization or person across organizations need to communicate, a reusable identity is valuable. And there are endless examples of where that might be. Supplier-vendor relationships are great. A vendor may serve multiple different suppliers, and in which case a reusable identity becomes, again, valuable. So there are many different examples. I could go on all day about where reusable identities have value. But let's talk more about where they may not make as much sense, because that also exists. Generally speaking, reusable identities have less value when that identity is used inside of an organizational boundary. So when a particular employee, say, wants to access information within their enterprise boundary, a reusable identity means a little bit less, because that organization was responsible for identity proofing and authenticating that individual to get access to their own systems. They put those rules in place. And so they have more faith in their own processes, and they have the liberty to change those processes at their leisure. So they have much more control over the situation. And that really is where reusable identities have less value. It's once you cross organizational boundaries and information needs to flow between organizations, a trust framework is really what's necessary to allow a reusable identity to achieve its true value. Hey, Denny, you're on mute.
I try to take out my background noise and I forget exactly where I am. But James Derrickson is asking a question. What requirements or thresholds are in place for a patient or person to assert their identity to get authorized access? And maybe Ryan, I'll turn to you on this one if you want to take a crack at it.
Yeah, so let me just tell you a story first. In the CARIN Alliance, we are engaged with the patient advocacy community and the caregiver community. And those who have chronic illnesses will frequently tell us that they have to actually access their patient information. Probably some have said 36 different portals because of all of the different entities in which they interact with. As they're telling us that, they have become experts in what their usernames and passwords are and the password resets that come through and all of the other stuff, but it's acted as a significant barrier to trying to get access to that healthcare information. And when we talk in CARIN, we talk about it in terms of accessing the data where, when, and how you want to achieve your goals. And what the patient access community, what the patient advocacy community have told us is, look, just give me my information. I need it. And I need to be able to manage it. I need to be able to see it. I need to know what drugs that I'm on and what drugs I were on, because it's not working inside of HIPAA today, and we need to change it. So the idea of the requirements and thresholds, so we said this reusable digital identity is, what if I could just prove my identity once and not have to do it again? What if that could be my choice, that I could make that decision myself to do that? Well, back to this idea of trust, we needed to have trust across different systems. And that trust allows for us to be able to then say, how do these things all work together? Well, one of the things is that we believe in here in the United States, certification of those systems. So there are entities called credentialing service providers or identity providers that do this for a living. They prove individuals' identity for a living. Folks that you probably will know, like ID.me or Clear or One Cosmos. These are entities that actually prove someone's identity as being, again, a credentialing service provider. Those entities can get certified by groups like DirectTrust and a group called Cantera International to say, hey, there's a standard out there. And the NIST actually developed a standard called Identity Assurance Levels and Authenticator Assurance Levels. It's called 800-63-3. And anyway, we could get onto all the dashes here. But this is an idea of saying, how do we figure out a way where you can assert your identity at an identity assurance level 2 and an authenticator assurance level 2? And how do we certify that? And so these entities, Cantera and ultimately DirectTrust, will be able to certify these credentialing service providers, so we have confidence that they are part of this trusted ecosystem. The challenge is that there are two different ways to actually do that. One is through API-based identity authentication, and the other one is PKI-based authentication. We needed a way to bridge those two worlds together in a way that is consistent in how, for example, when credentials expire. In the PKI world, they expire in one specific duration. In the API world, it expires in a separate duration. Well, we need to figure out a way to make that consistent. So within the CARIN Alliance, we developed a credentialing policy. It's on our website. It's under carinalliance.com under the digital identity section that you can read. It's 100 pages of wonderful stuff that we helped develop over the last 3 years. But it is an ability for us to set policy for how credentials, digital identity credentials, could be shared across different ecosystems where the technology may differ. So at the end of the day, if I'm a patient, I don't care if I have a PKI credential or an API credential. I just want to make sure that it's trustworthy, that it's been certified, and that I can use it anywhere that I want. If I'm using this reusable credential, think of it as log in with, right? I want to log in with this credential that I have, and I want to use it across multiple different data systems. And I just want to make sure that it works, it's secure, it's privacy protected, and it's consent driven. It's based on my own personal preferences is really what I want to try to make happen. And as Kyle mentioned, it doesn't work. Sometimes it may not work for everyone. There was a study done that basically said, look, would you like a public credential, like from for example, the federal or state government? Would you like a private sector credential? Or would you just like no credential at all and just authenticate yourself into every portal that you interact with, essentially every data holder you interact with? And the feedback was interesting. It was a third, a third, a third. We can't agree as America what we want. We want choice. And so we want to allow for choice to happen. And that's, what's going on. So again, it may not be the right thing for everyone. Some may not want to do that. They may want to actually authenticate themselves every time they interact with a data holder. But for some, they're more comfortable with it, and they may either want a public sector or a private sector a digital identity credential, which they can get. Login.gov is an example of a public sector credential that they can get to be able to authenticate themselves to these different data holders. So it just depends on obviously who you are. And the most important thing is, it's not a requirement. It's really a choice for individuals to make that decision themselves.
Thank you. Thank you, Ryan. Julie, we have a question from one of our audience attendees who asks, similar to an intra-organizational identity, how useful is a reusable identity for one master patient, for one individual, or an entity that supports individuals such as an HIE that chooses not to be a QHIN or joint TEFCA, that chooses to remain a network within itself. How useful is a reusable identity? Or can you talk about reusable identity in the context of an HIE that may not necessarily be a part of the TEFCA framework?
Right. So, in that microcosm of the HIE itself, perhaps if matching is solved and there's no need to have the person be signing into separate systems, there may be less of a need, except let me go into a specific example that answers another question too. Start by envisioning the patient portals that we use today. You are identity verified in order to access those, and you have the single method of authenticating to your one health system, let's say. The opportunity with digital identity comes about because of the existence of this patient access workflow in ONC certification and the technology that surrounds that. So built into 2015 edition Cures update, we have OpenID Connect and the notion of the FHIR user, which is resource information that can come back as part of an OpenID Connect transaction when it's a health IT situation. So the Fast Tiger team saw the existence of this technology and commingle that with the idea of the patient portal and the baseline identity proofing that you do to get your patient portal account, but separate out the part of the patient portal in your mind that signs you in from the data holder system and the data that you're accessing at that one place. And if you carry that authentication to another health system, so from that HIE to somewhere else, you can not only save yourself reproofing and managing a different set of credentials, but also you can have a unique identifier that patient portal or home system or HIE establishes, and then that high assurance unique identifier that is only used between health IT organizations and is kept private. We don't send it to Yahoo when you sign into Yahoo with it, can be used to match your records across systems. So as we proliferate digital identifiers, and I'm signing in with my, one identity, if I choose to opt into that at every health system where I receive care, or from my HIE to other places, out of state, anywhere in the United States, at least for now, perhaps internationally later, I know that health data that matches on that identifier is for sure going to be about me. So over time, we are eliminating patient matching issues and the patient safety issues that arise from mismatches. That's kind of why it's important, and important even for an HIE.
Thank you, Julie. Kyle, our colleague Dave Delano asks if you can describe how OAuth fits into the trust and identity framework. Would you share your perspectives on that?
Yeah, I'm happy to. This is really good.
Kyle, you're breaking up on us.
Allow me
You
to
might want
return to fits into
Okay.
this. Can you hear me now? Can you hear me
Yeah,
now?
you might want to. I don't know. Yes, we hear you now loud and clear. You're just having a little
Okay.
intermittency in your audio.
Okay, my apologies. The mountains perhaps are causing a little bit of interference here. Yeah, so allow me to return to the authentication topic quickly, and that will show how OAuth actually relates to a framework. So in the case of authentication, basically after identity has been proven by a particular user, that user will establish what they call authenticators with that server. It'll be a secret of some sort, as we talked about. Now, generally speaking, it's not useful to have authenticators with each one of your health systems that you want to access data for. In the case of, let's say that I'm a patient and I want to access my data from these various locations, because then I have to have different secrets with all these different servers, i.e. passwords all over the place. So in a framework, instead, there's a service provider, a credential service provider, that will bind my authenticators to my account after they've proven my identity. And then I prove my identity to that server, that credential service provider, every single time. And then after that happens, that credential service provider can then make an assertion, a statement, basically. And that statement says, I have identity proofed this user and I have authenticated this user. And then they can tell another health system that I'm trying to pull my data from that I've been authenticated. And they do so in a way using some cryptography. They basically sign the bottom of this contract or this assertion, and they say, you can trust that I have authenticated and identity proof this person. You can let them have access to their data. That contract, that sort of signature at the bottom, that is OAuth. And that's what this entire framework is predicated on, is where these service providers authenticate me, and then they make an assertion to the various data holders that I want to pull my data from, telling them, I am this person. You can trust that this is person because it's coming from me, and I'm part of a framework, and you can then return data to me. So that basically is how OAuth bolts into a framework.
Thank you for that. That's very helpful, Kyle. Thank you. Why don't we move on to our third question of the day? How do we ensure accurate patient matching in an environment? And this is related to what we were just talking about, Julie, especially to what you were discussing. But how do we ensure accurate patient matching or identity proofing in an environment where patient data is getting exchanged among more and more different systems that have their own different internal identifiers? You know, we're introducing a new identifier, a new authenticator into a system where there are legacy identifiers and authenticators. How do we begin to make this transition, and how do we ensure that this can support accurate patient matching and identity proofing? And Julie, I'm going to start with you because you alluded to this in your previous comments.
Right. I didn't mean to answer this entirely yet. So I'll elaborate. What we've done in the Fast Identity team is to recognize that these business identifiers do exist today. We see there's a potential to shore them up a bit. So whereas limited information might have been collected at a lower level of identity assurance or only in a self-asserted manner in order to create a business identifier today. I'm sure you can all envision stepping up to a level so that business identifiers created by Cigna, say, are all at a certain level of identity assurance. And they all represent patients who are identity proofed at least a level of identity assurance that is known to establish a unique individual in the real world. So we get to some of that sense where the individual identifier itself is a candidate for being the digital identifier we've defined in the HL7 interoperable identity and patient matching implementation guide. So at that point, the business identifier actually becomes a unique identifier that can be crosswalked in multiple situations and doesn't have to be stored as only in that pairwise relationship between an insurance provider and a practice, say, like we do today. Hopefully also, as I mentioned before, there are need for fewer of these business identifiers. So that identifier can be known and shared when I sign in with whatever my chosen digital identity credential service provider is, or, the way that Ryan's survey reflected and our Fast Identity research concluded itself too was that patient privacy advocates said they don't want to have a single identity service or a aggregator of identity services that knows everywhere they sign into at every different health system. They would like to perhaps have a different credential that they use if they want to not have a single entity that knows every healthcare provider that they visit. Or in the case of the folks with those 36 patient portals, they may absolutely want to have one identity service. No, they're not generally, we saw a Q&A question, they're not generally HIPAA covered entities, but they may go through an accreditation program just like, almost just like a HIPAA covered entity would, almost like a HITRUST, but that has some identity specific aspects to it. Those programs vary. We know there's programs offered by Cantara. DirectTrust has identity service accreditation programs that it offers as well. But I think that gets to the essence of how the business identifiers can coexist. That certification programs FHIR user has room for such an identifier to be shared at the time of authentication. And the model for FHIR security that is being developed by FAST for scalability and is adopted by TEFCA QHINs as well includes the ability to have these trusted identity providers establish reusable credentials and then share them not just within a single tightly coupled data holder system, but the identity provider can service, with dynamic discoverability, any health system that accepts the tiered OAuth protocol and can reuse an OpenID Connect credential that is trustworthy through PKI validation of that trustworthiness as their interactions with the client and the server are signed with their digital certificate according to the UDAP standard.
Thank you. Ryan, I'm going to ask a dumb question of you, okay? And that question, maybe it's not a dumb question, but I'm going to ask it anyway. We have an emerging kind of community of identity providers, reusable identity providers. Are we going to, by virtue of that, have problems with the matching or the assertion of a person being who they say they are, the associated authentication being complicated by the fact that some users may have multiple identity credentials? There's no way to say you already have, or maybe there is, you already have an identity credential. You don't need another one. You can use the one that you got from this certified provider of identity services. What if I end up getting 3 different identity credentials that prove that I am who I say I am and make it possible for others to authenticate me, but I might be 3 different people? At least, in my first impression is we see this with the adoption of a lot of API related technologies, is that we could still have opportunities for replication that runs against the intended purpose. Could you talk a little bit about that in sort of what does a world look like where multiple identity providers might be in the same system for even one individual or some individuals? Is that a reasonable question, or is that am I asking a dumb question?
No, I think it's a reasonable question, Denny. I would also caveat that comment to say that at best, we probably have a dozen of these around the country rather than the hundreds of data holders we have where our data is stored today, right? So it's a limited problem and it's a finite problem, but it certainly could exist. I think the challenge is with this issue is that this group well knows is the fact that patient matching has to do with the fact that there is no source of truth. Each of the organizations that we interact with keep that essentially data on us, that demographic data on us. And if we don't interact with that organization for another year and we've moved 3 times during that period, they don't have the latest demographic information. Therefore, trying to match that information that's in their old system with the one that I have now is problematic. The thing that's new about this is a couple of things. One is there are these credentialing service providers that could be able to provide reusable identity. The technology is where it needs to be. And in addition to that, the patient is going to act as their own source of truth. So they are going to be the ones to be able to tell the data holders, this is who I say I am. I went and proved my identity. Here's my credential. I'm going to use that in as many places as I possibly can. And that enables the individual to then control their own identity, be able to use it where and when and how they want, and be able to use it and hopefully in as many places, and that's what we're trying to make happen, as they possibly can. And when that patient becomes the source of truth, it kind of reduces that problem. Patient matching is going to be around forever. That's true. But can we reduce the burden associated with that correlates to both the patient and the provider, quite frankly, and the data holders themselves over time? I'll give you one quick anecdote, Denny, is that we're working with a very large health system right now who, like many health systems, are acquiring other health systems with other EHRs. And they're trying to figure this out, right? The amount of patients that are coming into their facilities potentially could be reduced in the sense that they don't know where their referral stream is coming from. And so they're concerned with the fact that I got to get outside my EHR, find out where the patient is, and then be able to take the patient, have a relationship with them, and no matter where they are, be able to integrate them in. For example, if they want telehealth services, I want to provide them telehealth services. I don't want them to send them to another portal and be able to go through some other process. I want them to come to us and we'll direct them. Here's where you go for virtual care. Here's where you go for in-person care. Here's where you go for behavioral health services. And I want to be able to direct them and have that relationship with them. Well, that starts and ends with the digital identity ecosystem. What they told us is they said, you know, we have this identity problem and it is a huge problem. And we spend literally tens of millions of dollars a year on this issue. And they said, if we can reduce it in any way, it would be helpful. And what they came to the conclusion of is, if we can move to more of a digital identity reusable credentialing model, it will literally save us tens of millions of dollars a year, because at that point, we can then be able to say, wait a minute, we can use that reusable credential. And when we do, we can update our backend databases with the most updated demographics that the patient is providing to us, right? This is my latest address. This is my latest phone number. And I'm going to keep that updated in my essentially credentialing service provider identity. And I'm going to give it to you. And now the legacy systems start to update their information that they have when they haven't seen me in a year with the information that we as patients are giving to them. That's a complete paradigm shift, Denny. We think it's going to happen because of, obviously, from an ROI perspective, it makes sense, but also from a business perspective, and quite frankly, from a patient friendliness perspective. I mean, it's just better for the patient. It's better for everyone involved that type of a model actually starts to exist in the future. And you'll see it over the next few years.
Terrific. Both Kyle, you and Julie have indicated you want to add a little something to this. Kyle, I'll start with you. You indicated it's a standards development initiative. And then Julie, I'll turn to you.
Yes, thanks, Denny. So I'm referring less to the topic on the slide, although it's related, more to your question, Denny, which I do not think was a stupid question. This is such a fun problem to think about because it is so daggone hard. Basically, to summarize your question again, I've got a credential over here. Let's say I have some kind of a unique identifier with that credential service provider, and various health systems use that to resolve my identity. If I give them this number, they know exactly who I am. There's no confusion. And then I go to a different credential service provider and I get another number. Now what? How do I get my data from these other data holders that are using the old number? What do I do? It is a really hard problem to solve. And PEARLS, which stands for, the name sort of does not necessarily represent its ambition. Privacy Enhancing Health Record Locator Service is really all about identifiers and identity resolution. It's an initiative that DirectTrust has been working on for quite some time. And we talked about this exact topic. And what we concluded was there are at least 4 ways that this, and when I say this, I mean an identity resolution capability may come about that's not government funded. I won't go through all of them, but I'll give you two general sort of flavors. The first flavor is you have one single identifier, and that's the one that you use throughout your entire life with every service provider and data holder that you interact with. You might call that an ideal state. And in some ways, the Social Security number, in fact, serves that purpose. It just doesn't do it 100% of the time, but it's not bad. There are problems with that, however. Social Security number has overcome a lot of those problems because it's government issued. But if it's commercial issued, to your point, how do you prevent a second one from being issued to the same person? Somehow that new credential service provider has to learn and understand that one's already been issued. I can't issue a new one. That's a really hard problem. So switch over to the other methodology that could also be used, which is you have a collection of unique identifiers and they follow you throughout your entire life. And some service provider of some sort, maybe it's a wallet, let's say, were to keep track of all these identifiers for you. And each one is globally unique. And every time you access a new data holder, you prove your identity, along with your assertion of, you've been authenticated and identity proof at a certain level, comes a set of identifiers that go into every single data holder that you want to access. And one of them is going to hit. And when one of them hits, you know exactly which records to return. So that's another way of doing it. You don't assume there's going to be one. There's in fact many, but some service collects them and keeps track of them on your behalf, and you're able to share them with everywhere you go. The jury's still out as to which one we'll try to land on here. This is in fact a standards development effort. We're trying to use prior art to understand what's been done, and we'll be inviting different approaches to present to Pearls soon to see how our criteria we're developing is what we want this solution, this standard to actually achieve, to see how they've worked through these same problems.
Thank you. Julie, we have, in addition to hearing your perspective on this, and in the very few remaining minutes we have a couple of questions. What are the chances, and this is, I think, a parallel or a corollary to the question that I asked earlier, what are the chances of digital identifiers being misused, such as identical twins using each other's digital identity? How does misuse occur in a system like this?
Right. Well, as with any credential that's strong assurance, each of the twins would be bound to a legal agreement that says they may not share their authenticator. So the likelihood of that, even as with a credential being stolen, is that the twins would have to collude and break the agreement with their identity service in order to do that. So I would say the twin substitution is not more likely than any other stealing of credentials. There is one of them would be committing fraud to take a photo and have borrowed the other's driver's license to identity proof as the twin. So there's that as well. We have some elements of U.S. mail and notice introduced to the identity verification guidance that are part of the FAST implementation guide. So, there are elements that have been planned as part of those standards. And certainly with the preponderance of identity foundation that exists in NIST 863 series of digital identity documents, that really eliminate those possibilities. Although, there are always going to be criminals and folks who break the law and commit fraud in the world. The other small point I would make, just dangling from the previous question that we've been talking about, is that some of the work we've been doing in FAST and in collaboration with CARIN as part of the digital identity proof of concept is to help identify in this scenario where there are many identifiers seeded into the ecosystem, the key demographics that help you make sure you're talking about the right person. So even in the case where multiple identifiers are trying to be bootstrapped and one system may not know any of my identifiers yet, there is metadata about me of sufficient diversity that we've established in this implementation guide that lets you have some certainty, you know, the person that you're talking about. It's not just first and last name and date of birth and not even address. It has to be something more than that, something that's been verified, like an email address that control of has been verified, the digital identifier that I can demonstrate I have control over, and then I'm matching on even things like the last 4 digits of my social security number. We know that that's not a number that we want to use for patient matching generally. Some systems won't allow it. It's not considered to be privacy protecting to share that, but the last 4 were positively received by the patients that we obtained feedback from and are known to be okay. Another aspect when we had our long biometrics conversation was that facial photo is useful in matching. And if you look at our implementation guide, there's a line item for defining how a facial photo can be verified along with an identity proofing process and then used in a match request to, as you can imagine, programmatically perhaps confirm a match on the other side if that same or a identical photo exists on the responding organization side.
Well, thank you, Julie. That's very helpful. And I want to thank the 3 of you for today. I know we've hit the top of the hour. I want to briefly let folks know about what's coming up next. We have alongside identity and authentication, these critical components of privacy and consent. We are going to be having Hannah Galvin, the Chief Medical Information Officer at the Cambridge Health Alliance, which is right down the street from where I am at this moment, and Seth Proctor, who's the CEO and founder of Tranquil Data, talking to us about another pillar, a critical, essential component to this new world of interoperability, and that is privacy and consent. So please join us on Thursday, September 14th at 9 a.m. Eastern Time. Hopefully some of you on the West Coast can join us as well. And take a moment to provide your feedback in our survey if and when you sign off today. So we're going to continue our conversation, and Ryan, Julie, and Kyle, you're welcome to stay. We'd love to have you around. We have a lot of questions I know that are coming from folks. So I'll defer to your judgment on if you're able to stay with us. But let's start with a question, Ryan, that I'm going to ask you. We talk a lot of, we see this in the world of APIs and interoperability, and the fact that, thank you, Sharon, for your compliment, much appreciated. We operate in a world where I have family members who have landlines. They don't like cell phones. They don't, live in the digital world. They live in a very real, physical, analog world. And are they going to be disenfranchised from this kind of system? Are there ways in which these identity services, these credentialed service providers can work with individuals who are not, digitally enabled, either by choice or by circumstance? Maybe, Ryan, I'll start with you on that, if you can lend your thinking and your expertise to that question.
Yeah, look, we've got to build systems, processes, and technologies that work for everybody. That is absolutely true, and we've got to find ways where that can occur. I would say though that we're in a situation now where we don't have reusable digital credentials almost at all. So for anybody, so we're kind of at a 5% or whatever kind of situation where it's very, very low. We're trying to figure out how we can maximize the amount of people that this will work for. So let's definitely find ways to make that happen. I would say though that these credentialing service providers, many of them have opportunities to actually do proofing also in a situation where people can be able to provide that proofing in person. NIST actually provides an ability for that to occur. There's also proofing, for example, over the phone, like via some type of a video chat. If someone were to go into a library and kind of go through that process of how they would proof themselves. Really, we're getting to a point where we can be able to proof individuals similar to how we do when we get government issued identities too, like driver's licenses and other things, where we can be able to make them as ubiquitous as possible with in-person, remote, phone chat, other things related to how they can be able to access them. So these identity providers are going to compete based on, how ubiquitous and ability for them to be able to access that information it is. And we hope they will. And the idea here is, how do we find ways where this could be expanded to the most amount of people possible? And I see Kyle had some comments as well.
Kyle,
Yeah,
your
thanks,
thoughts.
Thanks, Danny. So this is another very difficult problem. It's generally referred to by NIST as equity. And they spent a lot of effort on their latest revision. Right now, what CARIN and FAST and DirectTrust and Qatar are all sort of predicating their practice behave is in version 63-3, NIST SP. Can you hear me again? I'm getting a signal that my internet was broken out.
A little breakage there. Maybe if you close your video, you'll have a little bit of more bandwidth. Let's see if that works.
Okay, and it might just be, interference.
You're doing fine.
Great. Thanks,
Go
Danny.
ahead. Go ahead, please.
So ultimately, the next revision coming out is NIST SP 863-4. Now, that is not around the corner. We're looking at a couple of years here before that comes out, but it has built into it a lot of equity considerations. And of those equity considerations, they have sort of doubled down on this concept of it's not a trusted referee. It's called an applicant reference. And this is an individual that can vouch for the person, where that person may not have any kind of identity evidence at all. They might not have a driver's license or some kind of a state issued ID or something else they could use to prove who they are. All they have is this relationship with someone else who's going to vouch for them. And that is one way that they could get onboarded to get their digital credentials, is through this applicant reference. Now, authenticating that person later on is still problematic, because a lot of the times these authenticators rely on the presence of a smartphone. But there are ways around that. A FIDO token is a good example. And if they have a password, that is one factor by itself as well. So there are ways around it. It just requires some creativity. So it does not exclude. There's a deliberate intention not to exclude marginalized groups in this program, but it does require some more work and some more thinking about how to make sure that does in fact occur.
Thank you. Go ahead, Janice.
This is Janice CARIN from MHGC. I actually have a follow-on question around that, because we talked about biometrics earlier, and there are similar issues around biometrics where, for a variety of reasons, there are quite a few people where none of the more common biometrics activities work for them. They may not be able to have their eye scanned or their hand scanned, or their pictures may not be consistent for various reasons. They may not be able to fingerprint, whatever it is. And as we move more and more in that direction, has there been any discussion of alternatives on the biometric front as more and more people are starting to insist on biometrics?
Yeah, in the case of the biometric that is used in the fast identity solution, the profile photo is one of many options. There's not a mandate to use a profile photo. It's one extra tool in the arsenal, if you will. But other biometrics we are silent on in our implementation guide. We leave that to the NIST 863.3 and future series of the digital identity guidelines. Similarly, there are a variety of biometrics, and hopefully identity services will implement multiple options for those users. I think, The only risk there is, should we have only one identity service in the country that requires fingerprints, which I don't think is likely.
Yeah,
Patricia,
and I'll add to that.
I'm sorry, Kyle, go ahead.
Thanks, Danny. One thing to add to that is biometrics can serve a lot. They have a lot of value potentially in digital identity, both for identity proofing and for authentication. They actually are the only one that has dual purpose. However, in either case, they are not necessarily required. There are ways to go around those biometrics in either one of those circumstances. So I wouldn't necessarily say that we're going to be moved to a direction where biometrics are going to be required everywhere. That probably won't be the case, at least not anytime soon. But there are different types, as Julie pointed out, of ways that NIST is working on making them more usable and overcoming some of the problems that you've described.
Thank you. Patricia Reed, you've raised your hand. Please unmute and ask your question.
Can you hear me?
We can hear you loud and clear.
Perfect. So running both the patient mastering and interoperability for my organization, I can see how if you were to identity proof someone and you were starting from scratch where everything was equal, everyone, ingested that information, tied it to records, and you moved forward, that's great, right? But we have millions of records, duplicative records, poor quality records. And the big question is, how do we work towards adoption when there is so much cleanup and so much to tie the new data to accurately? And we can't remove people, and people make mistakes. That's, my team works data governance on a daily basis to try and correct errors made by users. So how do we move from the ideal, which is what we're talking about, to the reality where every system is integrated with this identity management and has tied all of their records to a single instance of that patient and can move forward?
So I'll start if you don't mind.
I'm assuming you. No, Julie, by all means, just give me 1 second. Patricia, you sound like you're talking from a provider organization. Are you able to share which organization you're speaking?
Sure. I work for Steward Healthcare.
Okay. I know that, but I wanted to ask you first. So thank you for sharing that. Julie, go ahead.
So just briefly, that's definitely something we've had in mind on the Fast Identity team. As you are well aware, it's an arduous task and not something that we expect of systems out of the gate. It's a next version of our implementation guide requirement. It is something that will take a long time to iterate too. But I think the version 1 requirements that we have within FAST will help that process, because already we're seeing the use of the matching rubrics that we've published for business to business relationships that are in partnership. So it's kind of like an extension of the own team. I think the matching rubric that we've created will help to do some of that work to manage on identities, as we've called it, and create processes for that deduplication itself. It is something that we envision will be a future state. In other words, we do realize the benefit of matching, even when probabilistic matching occurs, on responding organizations, systems that are organized based on identity. So you'll see that as something we refer to in the standard itself, and we think it's critical to get to a better probabilistic future state.
Thank you. We appreciate it. Go ahead, Kyle.
Thanks, Danny. Yeah, Patricia, this is a really, really good question, and one of the characteristics, and Julie just mentioned this as well, is I don't think that we're ever going to be able to escape entirely probabilistic matching. It just will not happen. There's no way to get away from it. It doesn't mean we can't use identifiers, though. So ultimately, one circumstance where that might occur is in the first time you have to match records. So you've got existing patients in your system, and you would like to move these patients over to, let's just say, some new yet to exist. Well, actually, there are different options. An HL7 identifier is one existing option. Let's just use that as an example. You want to move to an HL7 unique patient identifier, and you've already got records in your system that are not using that identifier today. How do you migrate those accounts over to using them? The first encounter that you have with a credential service provider that is engaging with your organization, for example, is going to have to match those records using demographics. There's just no way around it. You have to start there. But from that point forward, you could then associate that account with a unique identifier. And from that point forward, you no longer need to use identifiers. Now, there is going to be system cleanup. That's expected. There's no way around it. But you can actually reduce the amount of times you have to use and rely on demographics if you're able to use these identifiers going forward. But at a minimum, for the first encounter, there's just no other way to do it. You have to use demographics, and the FAST team has done an excellent job at mapping out what assurance you can place on those different demographics to be able to execute a match and then be able to switch over to identifiers as sort of a migration process going forward.
Ryan, you're nodding to these comments of Kyle's. What would you share with us on this topic?
Well, yes, it's extraordinarily hard, and we're grateful for Patricia and her team in helping to be able to navigate this through what's going on. But Kyle's right. That's what these health systems are telling us that are looking at actually being early adopters of this technology, is that we can actually reduce the burden over time. Certainly the initial is still burdensome. It's still going to be hard. It's difficult. The work that Julie's team has done is going to hopefully help in navigating that to some degree. But there is an opportunity here that if we can link them together and find a way where that can be done using a single credential, that helps to alleviate the problem over time and potentially even helps eliminate it, because it does actually get the individual out of the middle of the equation, or I'm sorry, get the organization and the systems out of the equation so that the individual becomes key to what is actually occurring. So it does help. The patient mediation part potentially could help as well. There's opportunities to kind of rethink how we've done this. Remember that we've got systems now where we just have antiquated information that's being inputted by individuals that obviously there's mistakes that are made related to that, and that's always going to happen. But if we can be able to solidify this into a single combined approach that has those identifiers tied together, I think there's opportunity there to at least reduce the problem over time, maybe not eliminate it.
Thank you. Janice, you have a question, either yourself or one from the audience. Would you share that?
Yeah, excuse me. I was wondering if you had any discussions or have any thoughts about tying in this type of reusable identity proofing and with some of the industry-wide patient matching efforts that have started being adopted, such as the Da Vinci member match mechanism that was designed for the pair-to-pair APIs that CMS is going to be requiring. Can you talk a little bit about how those types of things are tying together, if at all?
Ryan, I'll start with you, and then we'll pick it up from Julie and Kyle.
Start with Julie on this one.
Julie. We've
been asked to look at how attribution in member match relates to fast identity. It's been some time since I picked that up, but I don't think it's as specific of an issue. There is I can't remember the subtlety of it, but one, we are working to collaborate and shore up any differences. And two, it's a slightly different issue from what I recall. Perhaps the questioner could elaborate.
Janice, do you want to elaborate a bit on the question?
Well, I was using that as an example because that's the one that I am somewhat familiar with. But I just was wondering, as more of a general question of, as you're progressing along this approach, there are groups that are putting forward industry accepted mechanisms to do member matching or patient matching through more traditional means. And I was just wondering about how you see a convergence, if at all, and if you were working with any of those to work towards a convergence.
Yeah, I can speak a little bit to this. Ultimately, for better or for worse, you could look at this both ways. Digital identity itself, we'll call them identity credentials. This is the sort of construct that's used to make a statement about who I am and prove who I am, are in most cases agnostic to an identifier approach. In other words, these credentials are used to carry and prove possession of an identifier. An identifier is used for identity resolution, or what's generally referred to as patient matching. And so we're able to move the identity credential space forward and be able to federate identity credentials across various health systems. Again, a separate problem. Whereas solving that problem will allow us to carry an identifier within these credentials to these various health systems, which to a large extent remains to be seen as to what that identifier approach is going to be. A good example of to sort of conceptualize how identity credential carries an identifier is your driver's license. Your license itself is your credential, but you also have a number printed on that license. And the way you authenticate that license when you give it to somebody is the holographics and various security characteristics, but it remains an identity credential whether or not there's a number on that license. What that license is doing is it's proving your possession of that identifier, that state issued driver's license number on there. And identity credentials that are digital do the exact same thing. They can carry many different representations of identifiers. So we can move this forward without necessarily being slowed down by the identifier, identity resolution problem. Not that it's not urgent, but these two things can occur with relatively little challenges on one another.
Excellent. Any questions from other folks in the audience? Any other topics that members of this audience would like to address? It's been a great discussion. I'm
Yep.
learning a great deal and learning. I don't know a great deal at the same time. But any other questions for
we
folks?
do have
Janice?
one other audience question that I'm going to pose to the group since we have time.
Okay.
Excuse me. I did give my answer via text, but do you see that these standardized digital identifiers, do you see them replacing the existing individual identifiers being used in most locations, or being added, or like, are we going to end up in a situation where someone has a collection of standardized digital identifiers because not everyone's accepting all of them and some organizations are still insisting on their own? Or do you actually see a future where there's a more, where people can pick, this is the place that's going to hold my identity, and just use that everywhere?
As with many things, I think this depends on financial answers. Identity proofing someone is costly, both for the software or system that is performing the identity verification checks, and for the user on the other side who has to provide credentials that are good enough and take the time to take good photos if they're doing a remote identity verification or go in person somewhere. So I think that problem will sort itself out to some extent based on market factors, but and for that reason, we do envision ideally a future state where we have a limited number of credentials. In the case, like I mentioned before, of a complex patient, it's in my own best interest to have a single credential that I can make sure I'm stitching together all my records with. That might be a great way to operate in a TEFCA environment where I want to have one credential that does a network broadcast query and finds my data wherever it exists. There are other components that will have to go into that, like my previous addresses, so that a query on a variety of time frames of my health history may occur, where I lived in other places. So that involves verifying multiple addresses potentially before those queries can occur. But that would be, my sense. It will be truly, as Ryan mentioned also earlier, to a financial advantage to use reusable identity credentials, and hopefully, will then also protect from misuse of my health records, because I have established what my identity is and I have this very strong authenticator that is used to access my health data, and I have more of an opportunity to lock that down and make it very stringent to use, because it's not an email-based password reset across 15 different credentials, or 36 in Ryan's other example, that I'm having to manage.
Just to follow up, in a system where this is actually the way things work, how do you manage having, you see a mechanism by which someone can strike out certain data or exclude certain data from being collected by someone who has your identifier? For example, my standard example is getting an independent second opinion, but also in the current system, to some extent, if you go to a new provider and it's a disaster, and they're making, there's stuff that they put in which isn't true or whatever, you can exclude that from your setup by not allowing consenting to that being exchanged beyond that provider to some extent. And with a universal identifier, the patient gets less control. We're kind of inching into next month's topic, but we'll do this sort of transition. How do you see consent and the ability to not have certain information shared working in a world with a universal identifier?
I'd just say real quick, privacy minimization has become a best practice and really a floor in terms of how this actually operates. So as you think about this in terms of where this is going in the consumer world, folks want to figure out ways where they can, at least most organizations, minimize the amount of information that they're tracking and keeping track of, rather than maximizing that. Now, I know that seems hard to believe in terms of where we are at, but given what's happening on the Hill, and especially given some of the pressure that's being put on some of, obviously, the technology companies and others, I think it's doing, I will say, just from my personal experience, I downloaded my mobile driver. I said this yesterday. I downloaded my mobile driver's license in Georgia, and it was a great experience. It goes to my wallet. It's stored in the hardware of my phone. It's highly secure. I use it where and when I want. I go to the airport and I actually click on it just like Apple Pay and scan it. And the TSA doesn't actually capture any of my information. It just validates that I am who I say I am from a trusted source with the hardware of my phone. Doesn't go across the cloud, doesn't go across the, we're good to go. It's an ability for us to minimize the amount of effort doing that. To your point, Janice, and this is for next week, maybe this is a spicy issue. Love the work Hannah's doing. It's amazing stuff that's going on. But it's also a little bit futuristic because of the practical realities that we have in terms of HIPAA today as it relates to TPO. This is a personal opinion, by the way. The real question for next week, and you can ask Hannah this question, is how does an organization accept the liability of knowing what the patient's consent preferences are for how they want that data to be shared in a TPO related situation? Does an organization want to actually take on that liability? And that's been a huge question for years to do that. Not to say personally, I wouldn't want that, and I wouldn't want control over my data. Trust me, I've done this every day for the last 8 years. But there's a practical reality associated with that as it relates to how HIPAA works today and the policy construct that we're under, which that helps tee you up, Denny, for a spicy discussion next week as to how this is going to work. So
I can see, Kyle, you make a note of making a distinction between identifiers and authorization. Before we wrap up today, can you clarify that? Say a little more about that?
Yes, I'm happy to. I'm happy to. This in fact, this exact question has come up in pearls before, where many folks think that the sharing of the identifier is the way that you gate access to sharing data. And I might just personally argue, maybe not on behalf of DirectTrust, but just myself, that they probably shouldn't be. They solve different problems. Identifiers solve identity resolution problems. In other words, I have 5 John Smiths. Which one am I talking about? They do not solve the authorization problem, or that's not the intent of them. They could, but think of the example in a transition period where one user has an identifier associated with their account and one user doesn't. They didn't do it by chance or by choice. They did it by chance. That users that does not have the identifier are still going to get their data shared. They're just going to use demographics. So if you don't have an identifier or you choose not to share one, it doesn't mean your data won't be shared. It just means it might be shared less accurately or less consistently because you'll be using demographics instead of identifiers. So I wouldn't think of an identifier as being a way of gating or using as a construct for authorization. It's really an identity resolution mechanism.
Well, we're right at the bottom of the hour, and Julie Moss, EMR Direct and UDAP.org, Kyle Neuman, DirectTrust, Ryan Howells, Levitt Partners, and the CARIN Alliance. I want to thank you for spending your time with us this morning, especially Julie, you spending your time with us this very early morning. This has been a very thought-provoking discussion. We couldn't ask for 3 more thoughtful and informative and inform people to share their perspectives on this. And on behalf of MHDC and our community, I want to thank you for joining us today. I also want to thank everyone in our audience for joining us. It's been great. This is increasingly a more engaged discussion that we're having in our executive forum, and we appreciate your joining us and bringing to us your perspectives. When we sign off, you'll have a 1 second, I won't say 1 second, 15-second survey to complete. Please take your time to do that. And with that, I'll thank you, and we're adjourned for today. Have a great day.
Thank you.
Thank you.
Danny. Thanks all.
Bye-bye, everybody.
Thanks, everyone.